Salim. The style is the same as before. I think I've lectured to this particular group on at least one or two occasions. So we're going to probably look at maybe 2 or 3 cases in this instance, and I'm going to leave 15-20 minutes for general questions on ENT, emergencies or otherwise. So there'll be a series of questions on each slide as before, and concentrate on the questions that I ask you to respond to first. Don't get ahead of yourself, and put your responses into the chat box, and we'll interact that way. So is everybody happy? Got a pencil, paper, pen, paper to write your answers or type them in directly? So let's crack on. Okay, so one of the commonest presenting features to general practice, I imagine, but also to emergency ENT, is epistaxis. But tell me how epistaxis can actually present. So just give me some idea of how these patients might present. We know they get a nosebleed, but any special features about the nosebleeds and what they say in the clinical history? What's their presentation? It may be sudden onset. Yep, usually it's sudden onset because you don't normally bleed regularly through the nose. It's sudden onset. What other features are there that the patient complains of? I mean, is it usually spitting or coughing blood? Yep. Okay, so John, yep, I was going to ask that. Anterior nosebleeds, you'll have blood coming out of the nose, perhaps a little from the throat, coughing it up. Posterior bleeding, more likely to cough up blood. Yep, that's very important. So they say, not only am I bleeding, but I'm coughing up huge amounts of blood. Yep. Any other sort of presentations they might have, which we can mix in with the second question? They can't control it. Okay. It's a sort of a symptom, I suppose, Dr. Murali. Anything else that they might volunteer or you might ask them in relation to their nosebleeds? Either something unusual, frontal headache, they may have a headache, particularly if they've had an associated upper respiratory tract infection or something like that. Trauma maybe. Okay, trauma is pretty obvious. So what are the other sort of precipitating events then? John, any others? Anybody know what other precipitating events, something that might have happened? You may have got injured. Yeah, nasal infection and acute rhinitis may lead to this. Any other sort of trauma? Hot bath, nasal steroids. Okay, nasal sprays can certainly cause a dryness. And in a small number of patients, nasal sprays have to be stopped because they get recurrent small nosebleeds. Sneezing can cause it. Yep. Anything else? Anything else? Stress? Well, we're all under stress, Chris. It may raise the blood pressure and make any bleeding slightly worse rather than actually be the cause of it. Anything else? Anything else you might ask in the history or symptoms that might give you a clue as to the etiology of this nosebleed? We know that clearly a blood vessel has burst in the nose, but there may be a reason for it. And you've mentioned some of them, but there are 1 or 2 others. That's absolutely right, John. Are they taking any blood thinning agents? Yeah. Antiplatelets. Foreign body, yep. That's, but how would a foreign body, Chris or anybody else, how does a foreign body usually present in the nose? It's usually in children. Yep. Neoplasia you've got to think of, absolutely, Dr. Murali. So a foreign body, just hold on there, a foreign body in the nose, What's the usual presentation of a foreign body in the nose? Block, and not just a smelly discharge, John. It's absolutely horrible. Really, really disgusting smell. Okay, not a septal spur, unlikely to be a problem. Septal spurs have been in the patient for donkey's years. Okay. Any other thing that you might ask the patient in terms of the potential etiology of their, we mentioned anticoagulants. Anything else? Do you ever ask about bleeding or bruising? Yeah, recreational use of drugs. Yeah, I mean, those that you sniff up the nose may cause bleeding. I was thinking anything that might cause bruising. Anticoagulants have been mentioned. Is there anything else that might cause bruising or bleeding? Idiopathic thrombocytopenia. Okay, that's a possibility. So bleeding disorders, and these can be very subtle. For example, von Willebrand's, which you ask the patient, do you bleed or bruise? They say, well, I do bruise relatively easily. I hit myself and I come up in bruises. Because it's so common to them, they don't necessarily volunteer that information. So it's always worth asking. And then it's also worth asking whether in the family history there's any bleeding or bruising. Okay. Any other symptoms? We've mentioned nasal obstruction. We've mentioned potential neoplasms. We've mentioned foreign bodies. But what other part of the body is the ear, nose, and throat connected to, as it were? The interconnection. Climatic. Okay. Dr. Murali, nosebleeds worse in the summer. Anything else that might give you a clue that there's something going on in the nose, particularly in an adult, that's associated with epistaxis? A symptom they may complain of, or something you might find on physical examination? So which part of the ear, nose, and throat is the throat, or nose rather, connected to? It's connected to the throat, and we said people can cough up blood. Can you get any ear issues with nasal pathology? Yeah, okay, Chris, you called it eustachian tube dysfunction, but the symptom the patient complains of is what? We want the symptom. They may get a fullness in the ear, they may get a hearing loss in the ear, and if you look in the ear, they may have a glue ear or a secretory otitis media, a middle ear effusion. So nasal pathology, particularly neoplasms, very rare, but they may present not just with nasal symptoms, but the patient may also complain of ear issues. And if the epistaxis is due to neoplasia, they may have this additional problem in the ear. Okay, so taking a quick history is not that difficult, but you need to hone down whether this is a simple breaking of blood vessels in the nose or there's a more complicated background. So those additional questions are very important. So any questions on what we've done now, up to date? Any questions, or shall we move on to question 3? You all happy? Yes? Yes or no? Reasonably happy. Chris, okay. At least 2 of you are happy. Very good. Okay, let's move to question 3 then. Question 3. Symptoms of impending extremis. Now, the reason I put this in is that 99.9% of epistaxis is going to be trivial. But sometimes it may not be trivial. And that may be expressed visually with little or no blood coming out of the nose. But where's the blood going to if they're going to go into extremis? If they're bleeding from the nose, where's it? Yeah, they actually swallow their blood. It's called covert bleeding. So the amount of blood coming out of the front of the nose may be quite small in volume, but they're swallowing a hell of a lot. Now you can lose half a litre or a litre. And these patients, it's less, they may choke on or cough up the blood, Chris, but more likely they get an irritated stomach and they suddenly have a vomit of blood. But it's usually not blood in the sense of red blood. It's coffee grounds because the acid has decomposed the blood. So they may get a little bit of nausea, a bit of bellyache, and suddenly comes out half a litre or a litre of vomit of this coffee grounds. Okay, so be careful that there isn't covert bleeding because you can be fooled with the minimal amount of blood in one or other nostril. Where is the site of bleeding more likely to be if you're going to get covert bleeding? Which area of the nose? Not Little's area, Dr. Murali. Little's area is right at the front, and you're more likely to see all the blood coming out of the nose. And only if it gets overwhelmed will it go back, and they may cough up a little bit of blood. But posterior bleeding, remember the nose is 7 centimeters long. So the posterior few centimeters, the blood is not going to come forwards. It's going to go backwards into the oropharynx and be swallowed. So you're more likely to have covert bleeding which you cannot see with posterior nasal bleeds. Okay, so let's have some of the symptoms of impending extremis, because you can lose a pint or two very easily with epistaxis. So, okay, lightheaded, visual change in cognition, collapse. That is pretty extreme. Yep. So you get confused. You don't answer questions appropriately, and you may lose consciousness or collapse, John. Anything else before you get to that almost end stage, John? Hopefully you'll recognize some of the symptoms of extremis before they get that bad. Anybody else? This is important medicine in all aspects of medicine. So this is more general medicine. Symptoms of impending extremis due to blood loss. What are the symptoms and physical signs? Tachycardia. Okay, you get a tachycardia, and the tachycardia is increasing. Akaterica, yep. You may have hypotension, and the blood pressure, if you're doing it regularly, you see it beginning to fall. So a rising pulse and a falling blood pressure. Now, in the early stages of extremis, you may get a rising blood pressure, a rising pulse, but that maintains the blood pressure for some considerable time, and suddenly you decompensate because the tachycardia cannot keep up with the blood loss, and the stable blood pressure, which you think is fine, suddenly drops. That is bad news. So in any patients where you see a rising pulse and a maintenance of the blood pressure, beware. It's not because the blood pressure is normal, it's because it's being maintained by the tachycardia, and at any moment in the near future, the patient may decompensate and get a sudden drop, hypotension. Okay, so BP and pulse. Okay. Anything else? Anything else about the pulse? Any other clinical features of extremis? Very important to realize. Due to blood loss. Anybody have a comment on the features of the pulse in extremis? It's thready. Okay, so it's not bounding. It's thready, and what's the other thing about it? Thready, and what's that famous word? 4-letter word. It's weak. Remember, it's weak and thready. You can barely feel it. It's weak. It's not bounding like normal pulse would. So it's weak and thready. And if you look at their hands, what would you notice about their hands in somebody with extremis? Pallor, why is that, Chris? Anybody? Why is there pallor? Yeah, you get shutdown of the peripheral circulation to enable most of the blood to be centrally driven, and that's run through the sympathetic system with adrenaline. Okay, so you get peripheral shutdown and a reduction in peripheral circulation. So what do you notice about the veins on the hand? I mean, I've got quite large veins here. What would happen if I was in extremis? Anything else you might notice on the hand? What would you notice? Where the veins were full of blood, they've shut down. So you get what are called corrugated channels or corrugated veins. You know, corrugated roofs, they have that dip. So if you examine their hands, particularly, you see corrugations where the veins were. Okay. Now, one final thing that you might notice about the patient more generally, if they're in extremis. Remember, you're pouring out adrenaline, which makes your heart race, which shuts you down peripherally, makes you anxious. What else does it stimulate? Has anybody ever seen anybody in extremis? They're extremely pale, they're anxious, becoming confused. And what do you notice about the surface of their skin, besides the pallor and the vein corrugation? It may be mottled, but even more importantly, Kate, they sweat. They're sweaty, it's wet, clammy. That's it, Ollie. Yep, they're clammy. Okay, so there are probably half a dozen, maybe 10 symptoms and physical signs which tell you the patient is going into extremis. The first ones really are the tachycardia with maintaining the blood pressure. By the time the blood pressure drops, you're in a quite, way down the extremis route. And I think one of your colleagues, Chris, or one of the others, mentioned confusion and drowsiness and unable to tell you what day it is or where they are. They can get that confused quite quickly. So very important to understand these general medical aspects. You only rarely need them in general practice, and probably very rarely in hospital practice unless you're in the acute medicine sector. But epistaxis can sometimes lead to this, and you can also get bleeding, for example, from post-tonsillectomy. You can have massive bleeds from post-tonsillectomy, so you've got to understand the physical features and the clinical symptoms of excessive blood loss. Any questions? Happy? You did well there. Well done. Okay, so what's the immediate management of epistaxis? Can you list the sort of things that you might do immediately? And here, the assumption is that they've got an anterior bleed, because that's the commonest type of bleed. But let's see what you make of it. Lean forward, pinch nose. Yep. Is that yeah, lean forward, pinch nose. Okay, you can do a cauterization. Okay. So the immediate thing you tell them to do is pinch their nose. And where do you get them to pinch their nose? Ice on forehead. That's a way of vasoconstriction. Trying to get ice cakes may not be that easy, but it's well worth it if you can get it. So where do you apply the pressure? They say pinch the nose. It's amazing how often people get this wrong. Where do you pinch the nose? Yeah, you say the nostrils. Where exactly do you mean the nostrils? The cartilaginous part? Yes, yes. Remember, 2/3 of your nose is actually bone. The superior 2/3 of your nose is bone. It's called the nasal bony pyramid. It looks a bit like a pyramid, but then the bit that your mum, your dad, and your aunties and uncles move around, the distal third, is the cartilaginous part, and that's where you need to bring the two sides together to the midline, and you only need to press hard enough to overcome the arterial blood pressure. So you don't have to kill it like putting it in a clamp. You just need to bring the two sides together, open your mouth, lean forward. So any blood in the back of the throat, you can see it's not covert bleeding, it's overt bleeding. And how long will you get them to pinch their nose for? Seem to have lost my marker. What's happened to my marker? Reynold, I don't know what's happened to my marker. Sorry, ladies and gentlemen. Just seem to have lost the marker. You can see what people are saying in the chat box now. Reynold, are you there? Hello? Oh. Sorry, ladies and gentlemen. Let me see if I can find. I don't know what's happened here. I seem to have lost my marker, which I need to see what you're writing in the chat box. Okay. If the blood pressure is low and you don't have an intravenous line and all the rest of it, how can you try and maintain the blood pressure? Any maneuver you can do? You hear me? Sorry, I don't know what I've done. Give me a second. Sorry about this. Hello. I don't know what's happened with this. I've lost the pointer. Somebody wanted to annotate, and I'm just annotating. So can you just see what's happened? Yeah. Well, yeah. We don't need it. No, don't need annotation. And I can't. My pointer seems to have disappeared. I can't see it at all. So we need to. I got slightly lost amongst all this. Did everybody hear me? Tarika, John, Ahmed, Alim. Yeah, good. Okay. Sorry about that. I don't know what happened. So you did put a lot of those raise the leg, reverse Trendelenburg, foot end elevate. It's not just the foot, Dr. Morali, it's the whole leg. What's that against the wall? Legs up against the wall. Okay. Okay, plug it with gauze. 10 minutes, you hold it for 10 minutes. Yes, you say 10 minutes and they'll probably manage 4 or 5. What does Plavix and all these anticoagulants do, ladies and gentlemen, to your clotting? What does it increase? That's why I say 10 minutes. It doubles the bleeding time. So most anticoagulants will eventually clot, but it doubles the bleeding time. So things are just that bit more severe. So they probably take 7 to 10 minutes before they will actually clot. So that's why you're encouraged, particularly if patient is on anticoagulants, to pinch the nose for 10 minutes. Okay. All right, so that's the immediate thing. What else will you need to do? I mean, it's really bad. What do you need to do? They need to come in, don't they? And what do you need to do when they come in to hospital, admitted? What do you need to do? Yep. Anybody? Let's assume they're an extremis. What do you need to do? You might try and plug it with gauze, but even before that, remember they're losing blood. They're bordering on extremis. Yes, Kate, you get IV access. Yes, Chris, you may need to get bloods or certainly some IV fluids like Hemocell or even normal saline just to try and maintain the blood pressure. Because what you don't want to do is if the blood pressure drops, you're going to run into all manner of problems, including multi-organ failure, and particularly kidney failure. Okay, so you need IV access, okay, for fluids and anything that will maintain the blood pressure. Okay, and if you need special clotting factors, they can be given through the intravenous line. So you must have IV access. Worth getting blood cross-matched, as Chris has mentioned. Okay, so how do you stop the bleeding? You've already mentioned pressure, and then make sure the patient is upright. The top end of them is upright. That reduces the head of pressure slightly, makes it easier to clot. So you can use pressure. And if there's an obvious bleeding point, I think one of you already mentioned silver nitrate. If it's too much bleeding, you can't see, or electrocautery, not readily available, certainly not in this. Yeah, you can pack it. You can put an anterior pack in. You can use rapid rhino. You can use Mericel. What else can you use? What are you going to anterior pack with? Rapid rhino, somebody said, yes. Mericel, yes. Anything else you can use to pack the nose? Dr. Morali, lidocaine is a local anesthetic which you use to just make things a bit more comfortable, but you don't pack it with lidocaine. Depends on where you are. Okay, anywhere, Kate. Just tell me what you can use. Okay. You can just use a piece of gauze if it really is bad and you've got nothing else. You can use bismuth iodoform paraffin paste packing, which is traditionally, which you can leave in for a week or more, 10 days. Most of the other packs you need to take out after 2 or 3 days. They get very, very mucky. BIP, yep, bit more complicated to put in. One other method, you've mentioned Mericel, we've mentioned rapid rhino. A Foley catheter, that's a possibility if you don't have ordinary balloons, Brighton balloons, and the balloons that blow up anteriorly and posteriorly. Okay, so a Foley catheter is really for posterior bleed. If you don't have a balloon and you temporarily need to try and stem that bleeding before you get a more formal pack into the postnasal space, particularly for posterior bleeding. Okay, I think the only other thing you haven't mentioned are the balloons. So Foley catheter is a type of balloon, but there are more formal balloons that you can get, which you insert like you would with a rapid rhino or a Mericel pack. It has two channels. You blow the posterior channel up first. Okay, make sure it's beyond the postnasal space, blow it up and bring it forward so it jams into the postnasal space. And then you fill the other channel, usually with saline, and it puts pressure on the anterior nose as well. Okay. And if the worst comes to the worst, you have to take them to theatre. And what do you do in theatre? Theatre is, what do you do in theatre? Okay, you can do a sphenopalatine artery ligation, Kate. Yep, if you have the experience to do that. Not everybody does. So failing that, what's the alternative? Okay, you may put in a posterior pack, Kate, yep, into the postnasal space. You can make these up, or they come pre-made. Your nurses usually have made them. You put in a posterior pack and put in an anterior pack, probably bismuth iodoform paraffin paste. Okay, if there's, before we get to arterial embolization, if there's any obvious bleeding point, you will try and cauterize it and then wait to ensure that the bleeding has actually ceased. Arterial embolization you wouldn't do immediately. You would put the packing in, and if you get rebleed and a rebleed, then you might consider arterial embolization. And what's the secret of arterial embolization, and what is the risk? So you can embolize the blood vessels, but what's the risk? What is the risk of any embolization? Not necrosis. Anybody? Yeah, I mean, it's, yeah, the embolic material that you use, instead of going into the blood vessel where you want it to go, goes into a different blood vessel. And the problem is you've gone in through the carotid and you're trying to get to the sphenopalatine, but you may end up with the material going in the wrong place. And if it goes into the brain, you may well end up with a stroke. And in my, 30 years of ENT practice, I've seen this happen on at least 2 occasions. Okay, and you need to warn the patient. And it was a disaster in one patient who was actually a translator and spoke multiple languages. He couldn't work afterwards. Survived, but it was a disaster. So arterial embolization should only be done at a recognized center with somebody who's doing this sort of thing all the time. It's not for, and usually radiologists. So a radiologist who does 1 or 2 a year is not really good enough. You need to get these patients to a center where they're doing these on a regular basis. So embolization is way down the road. Think about it very carefully. Most epistaxis, if you can't stop it by local anesthetic and silver nitrate, you can usually stop it by packing and cauterization under an anesthetic, and maybe a sphenopalatine artery. It's rare that you would need arterial embolization. I haven't had one of those for probably 5 or 7 years now. Okay, any questions on epistaxis? We've rather harped on about epistaxis. Any questions? Oh, remember, pinch the nose. This is where you need to pinch it, not on the bony ridge. It's beyond, inferior, distal to the bony ridge. The blood vessels where they all coalesce, Little's area, is exactly where you need to pinch. Okay, that's where the majority of nosebleeds will come from. Okay, this was just some of the material. Nasal cautery, silver nitrate cautery, and then you got the various packs and balloons, and you got the bismuth iodoform paraffin paste packing material, which is usually about 5 or 6 feet long, and you build up the pack from inferior to superior in the nose. Okay, layer upon layer. It's not that easy, but you can do it. Okay, any questions? Okay, let's move on to a slightly different issue. What condition do these images depict? Venous sinus thrombosis, no. There's a huge amount of, orbital cellulitis is more likely to be the diagnosis. You're very specific there, John. Good. Preceptal cellulitis. It may well be an abscess, but certainly an orbital cellulitis. Okay, or periorbital cellulitis. So this is rather late stage. What are the early symptoms of an orbital cellulitis? I mean, if you look at the age of the individual here, it's quite young, isn't it? That may give you a clue as to why these, what other symptoms there may be present. Pain, okay. It's really rather painful. If the child is of an age where they can talk, they will tell you it's painful. Yep, it's very painful. If you have adults, it's excruciatingly painful, they'll tell you. Any other symptoms? You may get blurred vision. Yep, Dr. Morali. Yep, if they're able to respond to you. Yep, blurred vision. Anything else about the eye? It may not just be blurred, pain on eye movement. So there's obviously pain on eye movements, but there's limitation of eye movements. So when you get them to follow your finger, one eye is not going to move as well as the other. So what do they complain of when you move one finger? What is that symptom that they may get? They may get diplopia, double vision, and they may even not recognize the number of fingers that you put up, okay, because a bit of their vision is actually missing. Okay, so they may get scotoma. Anything else about their vision that indicates a serious problem, pending serious problem? Because if it's a cellulitis bordering on abscess, yep, the fovea, F-O-V-E-A, is very sensitive to pressure, and therefore color vision is the first element of the vision that seems to go. So they lose their color vision. So well done, Ollie. Okay, anything else? It's swollen. The eyelids are swollen, aren't they? And anything you notice on this image here, the top image here? Yep, Ollie, you get proptosis. So the eye is pushed out. So proptosis is common. The only way you can really identify that is look down from the top of the head, and it's pretty obvious here, isn't it? And sometimes the lids are so swollen you can barely open them. Okay, anything else? Because a periorbital cellulitis or abscess is going to be preceded by what usually? There's a condition that usually precedes it. So what are these young kids likely to have had in the previous days, maybe week? Well, okay, we call it possible sinusitis, but an upper respiratory tract infection, Kate. That's good. So they probably have a snotty nose. Okay, they may well have a snotty nose. They may have discharge coming out, and the parents say they were suffering a cold, and they just didn't seem to get better. They got worse and worse. Anything else which indicates that there may be a rise in their intracranial pressure? Remember, an orbital cellulitis, you've only got the cribriform plate, you've got the skull base, and things may go through the skull base quite quickly. What else might there be present? Any other symptoms? Yeah, headache. Adult will certainly complain of headache, but anything else? Headache? What else might indicate a rise in intracranial pressure? Drowsiness, yep. Vomiting, yep. Anything else? One other thing, particularly in adult. We mentioned this earlier on. Photophobia, okay. I'm thinking more of confusion. Okay, drowsy and they're confused. They don't know where they are. They may not remember their date of birth, their address, or what year it is, or who the Prime Minister is. Although, who is the Prime Minister? It's still Boris Johnson, isn't it? Yeah, just about. Okay, so these are symptoms that that you need to be aware of. Okay, and you can go from a relatively normal child to something quite serious very, very quickly. Okay, so always beware. A deteriorating child with unilateral symptoms in and around the eye associated with an upper respiratory tract infection may mean an impending orbital cellulitis. So it's worth referring these patients in. Okay, well done. Sorry. So what's the management? When it's like this, what's the management? Okay, so they need to be admitted, Alim, yeah. High dose intravenous antibiotics and regular review, looking at their... Okay, how do you know there's an abscess there, Dr. Laird? Because if you're concerned, what should you do? You should do a CT scan, absolutely. So if there's any concern that there is an abscess, you must do a CT scan. And if the patient's deteriorating in terms of level of consciousness and confusion, etc., a CT scan, because they may well require sinus surgery and decompression of the abscess. Okay? That's really for secondary care. The most important thing is that you, as doctors, mainly in primary care, should recognize the difference between a simple eye infection associated with an upper respiratory tract infection or whether it's cellulitis. And those clinical symptoms and signs that we mentioned earlier are very important for you to elicit. So any questions there? No? Okay, if we're happy with that, let's move on to the next one. Okay, so look at this image of the oropharynx and list the potential clinical symptoms. I want the symptoms that the patient complains of. That's what they're going to come to you with. So what's the diagnosis first? And then the symptoms they may complain of, given this appearance. Okay, it's an acute pharyngitis. Okay, can we be more specific than that? It's probably not the whole of the pharynx, because remember, whole of the pharynx would be the nasopharynx, oropharynx, and laryngopharynx. That's usually what you get with an upper respiratory tract infection. Although this is part of the upper respiratory tract, it's very specific, Dr. Murali. What do you think it is? Anybody else? Okay, exudative tonsillitis. Okay, let's call it an acute tonsillitis with considerable slough and exudate. Now, with this type of exudate, okay, what do you think the other symptoms are? And with this acute tonsillitis, what do you think other symptoms are? Okay, pain on swallowing, yeah, but pain generally, not just made worse on swallowing, Dr. Murali. Odonophagia, yeah, pain on swallowing, but pain generally can be very, very excruciating. Anything else? Okay, halitosis, fine. They're usually less complain. Okay, they may well have a fever. Yeah, pyrexia, that's good. Anything else? Anything else? Yeah, they have general muscle aches, Dr. Qureshi, myalgia, headache. Yeah, so they have constitutional symptoms, lethargy, fever, muscle aches, headache. They just generally feel lousy. Anything else? Whenever you have an infection in one side of the body, what do you always examine in the region? Yep, you examine for regional lymphadenopathy. Yes, Kate, well done. Yep, you examine for nodes, Dr. Murali, well done. So you end up with neck nodes, okay, tender, swollen neck nodes. So they say, I've got neck swelling and it's painful. What else? Anything else they complain of? Let me give you a clue. What nerve supplies sensation to the oropharynx? One, possibly two, particularly the tonsil. Which nerve supplies sensation to the tonsil? And that may give you a clue as to an additional glossopharyngeal. Yeah, so you make it otalgia or earache through the glossopharyngeal nerve that also supplies the middle ear. So they complain of earache. Okay, anything else? These look like fairly large tonsils, don't they? They're almost pretty much meeting in the midline. So what else might they compromise? Extremis, yes, Kate, very good. Because the muscles of mastication sit here, the tonsil sits here. If the tonsil's inflamed, the muscles of mastication cannot move so well, and so you get trismus. Yep, Dr. Morali, if the tonsils are very large, you may get airway issues. So the patient lies back and they find breathing difficult, or when they go to sleep, they're on their back, they snore like a trooper. So they end up leaning forward so they can breathe a little bit easier. Okay. I think anything else, because what do you think the underlying bug is in this particular image of an acute tonsillitis? A strep, Kate, normally gives you punctate slough, spots. So this doesn't look, this is like a gigantic spot. So could be strep, unlikely, given how huge the tonsils are and that the slough is almost sort of uniform. So what else might this be? What do you think the etiology that is going around in your head? Okay, the tongue looks very furry because they're dry. Diphtheria, yes, it's rare as rocking horse manure in the UK, Chris, but worth remembering. Diphtheria is pH as well, I've just noticed. Diphtheria. Been teaching my granddaughter phonics and realized pH is always pronounced ph, diphtheria. No, there's one other thing that's fairly common that you need to think of. This sort of slough. Yep, Chris, absolutely, yeah. Epstein-Barr virus or glandular fever. Yeah, well, it's not really thrush, I don't think, Kate. Thrush is sort of stuff you can very easily get off the candida fungal infection. You can get very easily scrape off and leave an underlying raw tongue. I think this is just because they've had such extreme infection. It's not. I don't think it's thrush. The appearance would be different, much whiter than this. Okay, so we think this is possibly glandular fever. So if the patient was complaining of abdominal pain as well, then what would be your concern? If you think this is glandular fever and the patient says, I've also got bellyache, what might you be thinking about? Absolutely. Splenomegaly or hepatosplenomegaly. These viruses can affect the liver, and in many instances you get a derangement of the liver function and the liver enzymes. Usually not too bad, and it generally recovers, but occasionally you get it very severe. So these patients can be in extremis with liver problems, and they can get a splenomegaly. All right, Chris, thanks for your input. I'm only going to be another few minutes. Thank you. So if they've got abdominal pain, you've got to worry about the liver and the spleen being affected, and certainly they should be in hospital, possibly having an ultrasound to check the size of the liver, check the size of the spleen. As I say, generally speaking, it settles down. Okay. So any sore throat with excessive abdominal pain with the potential appearance of glandular fever, think about liver and spleen. You can sometimes get bellyache just due to additional lymphadenopathy in and around the aorta, the descending and abdominal aorta, but the pain, abdominal pain with glandular fever and liver and spleen problems, if you palpate the liver or blot the spleen, it's actually tender, and you may actually be able to feel the enlarged organs. Okay, any questions on just this appearance? So we're almost there. sorry, let's go here. So list the key aspects of management in somebody like this. Remember, they're not being able to eat and drink. They may well be drooling, so all their saliva's being spat out. So what are you going to do? Any of these you can treat in primary care, obviously, but if they're this bad, what do you need to do? You need to admit them. Yeah, make sure, yeah, you need to admit and get an intravenous line. Now, what are you going to give through the intravenous line? Admit and put up an intravenous line. What are you going to give? Fluids, pain relief, and what else? Importantly, what's RL? I'm not sure what RL is. Dr. Morali. Fluids and pain relief intravenously. Antibiotics, yep. We don't need to go into detail of precisely which type of antibiotics. Obviously, you'll do a full blood count, glandular fever test, okay, and liver function at a minimum. And if they have breathing compromise, what else might you give them a stat dose of to reduce the swelling? You might give them steroids. Okay. So in this sort of instance, I might consider 120 milligrams of steroids. They're being covered by antibiotics, so it's fine. Or you can give them 4 or 5 milligrams of dexamethasone, which is a very potent steroid. Okay. Is it worth taking a swab? Yes. What are you hoping to find? They may give you the bug, a strep or staph or something like that, but generally speaking, they're not terribly helpful, but we always do them. By the time the swab comes back and you've given them a day or two of intravenous high-dose antibiotics, they're usually getting better. There's no point in changing unless you need to change based on the swab result. And what blood parameter do you use to see if the inflammation is improving? There's obviously the clinical improvement, but what about the blood elements that show you things are improving? What do you measure, maybe on a daily basis? You do a full blood count, but what in particular are you looking for, Dr. Morali? You've got to order the test, but then you've got to decide what ones you specifically need to look at. White cell count and the CRP, yeah. I mean, those are the ones that are usually coming down. If liver function was an issue, it's worth just monitoring the liver function to make sure if it was deranged that it's not getting worse, in which case it might be worth calling in the general physicians to have a look at it. But generally, even if it's quite high, it generally settles. And you certainly, once the patient is over their acute episode, it's worth measuring the liver function test a month or so later to make sure it has returned to normal, because a lot of these patients will want to drink, and it's not good to drink if your liver function is deranged. Okay. So, any questions on this? I think you've probably heard sore throats many times, but hopefully I've given you an extra little slant and window on how to manage, assess and manage these patients. So any general questions on this type of sore throat? No, you're all happy? Okay, we'll call it a day. But if there are any other specific questions on the 3 cases or any other ENT questions, we can spend 3 or 4 minutes trying to address those. So let me have any other more general questions or queries that are bothering you, and I'll try my best to address them. So pop it in the chat box, please. Thank you, Dr. Murali. Any questions? Guys, we can sign off. So thank you for your attention. I hope you found it useful. You were certainly very interactive as an audience. I hope me pressing you on things has made you think and logically enable you to gain educationally to better treat your patients. So thank you very much, and good luck in your continuing course, and I'm sure you'll do well, and I hope to speak to you again sometime in the near future. So thank you.